self-expanding valves used cautiously. And I think I have my slides now. Thank you very much for the kind invitation to present here. It's a pleasure. So just a brief comment before going to my presentation about Portico, because I heard about something about thrombogenicity and that the previous speaker would never use Portico in small sinuses. There are some criteria, but there is no real issue with Portico in small sinuses, and we may discuss that later. So repositionable self-expanding valves, currently the ones that we have are the Evolut R, the Portico valve, and the Centera. I have most of my experiences with Portico, so I will concentrate on that, if you don't mind. But I think the concept is more or less the same. Introduction of this feature of valves that were able to recapture and reposition, I think, made a great deal of difference in TAVI. But in order to have all the benefits of this new feature, you need to understand how and why and when should we do this recapturing and repositioning. So recapturing in the valves that are available now can be performed within seconds, which is good. In my experience, the recapture rate with Portico is approximately 25 to 30%. So I have a low threshold for recapturing this valve. The question is it benign? Should we use it? Or are there any issues related to that? And when would we take that decision? So there are different ways to recapture a valve. You can even either recapture completely, so the whole valve gets in the sheath, or you can do a partial recapture. And with a partial recapture, you may dislodge the valve and stop having the valve touching the LVOT or the aortic annulus, which gives some mobility to the valve. So there is a point where the valve, when we expand it, stops moving and becomes anchored in the aortic annulus and the LVOT. So sometimes this partial recapture is also very important. So we do it for better positioning. We do it if we have any doubts about the optimal expansion of the valve. We may even do it if we believe that the valve is tilted and we're not satisfied on the axis of the implantation. Of course, obviously, we will do it when we have a valve pop out while implanting the valve before the final release, of course. And we may use it as a bailout when we see that during the implantation we have an issue with the patient, any issue like the drop of pressure, some arrhythmia that may be worrisome. So having these valves allows us to recapture within 10-15 seconds and then pull the sheath back and reconsider, which I think is very important. Now, repositioning. Okay, since we have recaptured the valve, we can do the repositioning in a different depth. We can do it in a different axis. We can do it slower or faster. And this is very important. Sometimes we need to do a very slow valve positioning. And this is of paramount importance with Portico. And I have two examples that I will discuss with you later. And there are some lessons that we learned the last couple of years when we used this valve. Maybe Kostas or others would like to comment on the Evolut R in relation to this part, on whether we should do a slower or more faster positioning of the valve, and this may have any implication on the way the valve sits in the native aortic annulus. And the other question is, we can do it with or without rapid pacing. Sometimes we need rapid pacing, other times we don't. So, use cautiously. I agree with the title of the presentation, although that was not my idea, it was probably Kostas' idea, because recapture can provoke some valve dislodgement, debris dislodgement. So it may theoretically increase the risk of stroke. If we manipulate a metallic frame and we position and reposition like 2 or 3 times and push it and pull it not cautiously, we might cause problems. Another issue that we have that has occurred rarely, fortunately, is that when you recapture the valve and you're not careful on which level you have your sheath in, you may grab the native valve with your sheath. So when you do that, you cannot fully recapture the prosthetic valve, and your sheath may also be stuck there. It's very rare, but it has occurred. So anytime we want to recapture, we should be cautious on that part. Another thing is that when we implant the valve, sometimes we are pushing or pulling or doing nothing on the sheath. So this means that we may or may not have some stored energy in the system, which means that when we partially recapture the valve and the valve stops touching the LVOT or the aortic annulus, it may move in both directions, upwards or downwards, or it may stay. If I give an example, if you recapture a valve and you push, at some point the valve will be in a flower position, and if you push, you may really perforate. On the other hand, if you recapture a valve and you have some stored energy pulling back, it may pop out and scratch the aorta. So this is important. The stored energy in the self-expanding valve in relation to the system and the wire is very important when we decide on a potential recapture. And the last comment I would like to make is that any reposition may result in a worse position than the original. You're never sure. So when to recapture also relates to your expectations and what you need to accomplish. And of course, this comes with experience, I think. So I'll just show you two examples with the portico valve. When this valve was launched, it was the first and the only valve, transcatheter valve, that could be recaptured and repositioned. So it was a very, very nice to have it. Afterwards, we had the Evolute, which is also great. So I have an example here, and I would like to ask you to comment on whether we should recapture and reposition this valve. So this is a portico 25 millimeters in a patient with a previous bypass, and that was done in July 2014. So this is the baseline angiography. We see the sinuses. We do a BAV. I like to do, as Kostas does, also an angio, if there is no issue with the kidneys, because you have a better understanding on the occlusion of the coronaries or how occlusive the valve, your valve might be later on in terms of aortic regurgitation. So the valve is now start to implant. We see this dot. This is supposed to be in the lower part of the pigtail, which is not bad. And now the valve starts to flower. A few more rounds, angio. I think we're quite optimal depth here. And now I would like to ask the experts or the panel or whoever has experience with these valves whether we should continue or recapture. Would you like to comment on that? Somebody? You would continue?
Are you going to have a pop out here?
We'll see. Okay, so we continue. So there is one thing that you may see here, that the valve doesn't touch the opposite part of the annulus, okay? We continue. We do, but we saw it. So we say, okay, let's do an orthogonal view, see the expansion. We saw this under expansion, which is very obvious in the orthogonal view. But nevertheless, we say, okay, maybe it will expand at some point, or we'll do a BAV afterwards. So we say, okay, deploy and pray. The depth is good. This patient has obviously a working bypass graft. And this was afterwards. So I don't have the actual pop out, but it did pop out. And the reason, so you got that. Yeah, the reason is that, and we discovered that the hard way, with portico there is a few cases that when you have a very heavily calcified valve, you may have a cell bunching capture between the two leaflets, so the valve was not expanded. So how do you deal with that? This is not about recapturing now anymore. This is about saving the patient. Good news is that the patient had a bypass. There was no issue with the obstruction of the coronaries. We managed to snare the valve. Sometimes it's not so easy to snare these valves. This took like half an hour. So I don't have it here. Pulling back the valve because we want to bring it higher to the STJ. Nothing happened. Then we need to implant the second valve, valve in valve. I have another question for you. So it's again about recapturing. So that's why I continue. Not the very best case. So a stiffer wire because we couldn't cross the first valve. This is a backup Mayer. It didn't work. Then I think we used a Langerquist. Then we used this trick with a snaring the nose cone of the second valve. Not so important for this presentation, but what is important now is I want to ask you, I will just move forward, flower the valve. I would just want to ask you if you would recapture again here. Would you? You would recapture, Kostas? Really? Why? If you want to take the microphone because we have a live transmission and people are watching.
No flow in the coronary sinuses at all.
Okay.
I would take the
One more
first valve
shot.
higher.
You would take the first valve higher. Okay, yeah. That was, we wanted to do that, but it wouldn't come higher. That's the problem. So how about this depth and the expansion? Would you recapture?
Better than the first one.
Okay, thank you.
And also, when this one opens, it will touch metal to metal, so it will be more difficult to move.
Yes. So this was I think we're reaching now the third hour of this case, just to put you in the cath lab. It's 3 hours now, because it took us time. The patient is not doing very well, so we just released the valve. The patient had a drop in blood pressure, and on top we had some moderate AI with BAV. There was no issue with the coronaries, at least obvious. Maybe the Lima helped us here. The patient is doing well. We do also a post-dilatation BAV. And I don't have the final image. We saved that contrast injection. But the result was good. The mild AR, improvement in EHA class, patient was discharged, everything's fine. But I think that's an interesting example on to recapture or not recapture. So and I have a second one which is shorter. I think I have another 2 minutes. So this was the first time I observed a life that was saved because of a valve recapture. And we have a Portico 23 millimeter valve in valve in a mitral flow 17 for severe AR, dilated LV, and the patient is on deep sedation. I'm not doing the case, I'm just observing. This is the case of Dr. Jäger in Basel, January 2014. So this is the case. Not too many slides here, but I think it's interesting. Okay, flower. Coaxiality is not so good for my taste. But, okay, I'm not doing the case. I think that was his third valve. And then I think he considers that this is a bit deep. And he's pulling back. And this is what we have. We have a cardiac arrest. We haven't recorded the part when we recapture the valve, but there is free AI on a dilated left ventricle. The patient is arrest, non-intubated, because it's conscious sedation. So the valve is recaptured. We're doing CPR. I helped a little. And this is 40 seconds later. The valve is in place. And this is the final result. The patient wakes up, says, what happened? So I think this is a very interesting example of how these recapturable valves can save lives. And as the patient was discharged, everything went well. So in conclusion, I would say that recapturing recapture and repositioning can allow us to optimize several TAVR parameters, as we discussed before. Sorry for the typo. Provided it is performed cautiously, it should be used without fear, I think. And nevertheless, we should always bear in mind that perfectionism doesn't always result in perfection. So we should be cautious on that too. Thank you.
As always, a very interesting presentation. Has it ever happened that you have given up on repositioning the valve and switched to another valve? So how many times you attempt to recapture? What is your record in your personal experience?
Yes, well, there is a cutoff, and St. Jude was quite strict on that, and so it's 3 times. After 3 times, you need to change the valve.
Okay.
because it has not been tested in recapturing and repositioning to more than 3 times. I think we have done it up to 5. I think we did one together, Kostas, with 5.
Don't say it loud.
Yeah, but that was 5 years ago, so it's fine. Yes, sure.
Of course, yes.
Can I ask something?
I think if I can make a comment, I think, again, there are many things to observe here. And the main problem comes is because the first time you deploy, you're generally on the lower side. So second time you try and put it ideal, it comes high. And then third time, because you can recapture it only 3 times, you are then pushed to deploy it wherever it goes. So I think many times you have to observe a lot of things. If it's a small annulus, you have to get optimal position, pacemaker issues if you are deeper, so aortic angulation. So there is a lot of thought process, including what kind of wire we use for each anatomy is different. This allows you to get the best position to start with. The second issue is the stroke, whether repositionability leads to multiple recapturing leads to high risk of stroke and in Lotus, as we have observed, multiple repositionability can increase the risk of pacemaker. So I think there is a lot of trade-off on one hand, and on the other hand, it's a very useful technology to use it.
I think if you do it very carefully and gently, it's fine. And one last comment on that. I do these cases with a partial recapture. So the crucial point is the point when the valve is touching the wall, so it stops moving. So on that part, even with 2 or 3 rounds, which is partial recapture, you can dislodge the valve, make it move. And I think this is crucial, and this comes from at least my experience on Amplatzer devices when we put plugs in, ASD closure devices or LA closure. So it's more like forming the valve there. It's not implanting the valve. So I don't know if I describe it properly, but this is how I do it.
Do you think that we must follow some different rules when pushing or pulling the valve? Because if I put from the beginning the valve a little deeply, pushing it, it's not so dangerous as pulling it is not so dangerous as pushing it.
Yeah, every valve is different. With Portico is different than the Evolut. So it depends, I think. Sometimes you need to push, other times you don't need to push. At least with my experience with Portico, you have to be neutral at least at the end. At the final deployment, you need to be neutral. You shouldn't push or pull. I don't know about, we usually wanted to push the Evolut. I don't know if you still do it, Kostas. A little at the end. But I don't know, I use mostly Portico now, so I cannot comment for the Evolut. Maybe somebody else would like to comment on that.
And another very quick comment, if I can, is coronary obstruction. As you showed very nicely, both Evolut and Portico, because you can only recapture at 80%. According to me, there's no use of that feature for coronary obstruction, because once you release it, the shape of the valve is completely different. So I think repositionability is more important to get best position, to be honest. There is no other value into that feature.
Time pressure.
Thank you.
Ευχαριστούμε πολύ. Επειδή μας πιέζει λίγο χρόνο, θα καλέσουμε τον επόμενο μιλητή, τον κύριο Tsikaderis από το νοσοκομείο Άγιος Λουκάς της Θεσσαλονίκης, to present his best and worst transcatheter aortic replacement. Κύριε Tsikaderis.
Απλά για να είμαστε συνεπείς